Hello, welcome back to my channel. Today we are going to continue with the rest of the anti-ulcer agent, but in this series we are going to make use of question and answers guide to discuss the other classes of anti-ulcer agents. Thank you, let's go. So we will start with the H2 receptor antagonist. We've already done the proton pump inhibitors. So the first question is, between H2 receptor antagonist and PPI, which one is more effective and then why? Between the H2 receptor antagonist and PPI, which one is more effective for acid suppression and then why? Alright, so first of all, the PPIs are more effective than the H2 receptor antagonist. So that answers the first question, meaning to select between a PPI and H2 receptor antagonist to treat PUD. Our first option will be a PPI because they are more effective than the H2 receptor antagonist. Now, to explain why are PPI more effective or why are H2 receptor antagonists less effective? We'll focus on this pathway. This pathway talks about how acid is produced. So first of all, we will consider the right side of the pathway. When there is a stimuli, as we already said, when you think of food or you smell of food, the J cells in the stomach are stimulated. So they will be stimulated and then they will produce this hormone, gastrin. When the gastrin are produced, they also stimulate mast cells to release histamine. So the gastrin will stimulate the release of histamine, and then histamine will bind to their receptor. In this case, the receptor is H2 receptor. And when the histamine binds to the receptor, they also stimulate the proton pump, which is the hydrogen potassium ATPase, producing the acid. So our H2 receptor antagonists, they will act here. They will come and block this receptor. They will come and sit on the receptor so that histamine cannot bind to it, so that the proton pump can't be stimulated and acid wouldn't be produced. So why are we saying they are less effective? Because of this pathway. Aside this pathway, there is another pathway where acid can be produced. And let's see. The same stimuli will stimulate a nerve known as the vagal nerve. And this vagal nerve will lead to the production of what we call acetylcholine. It's a neurotransmitter. So this will lead to the production of acetylcholine. And when the acetylcholine is produced, they also come and sit on their receptor, here, the M3 receptor. And then they can also stimulate proton pump to produce acid. So in this pathway, you could see that there is no histamine involved in this pathway. There is no histamine receptor involved in this pathway. So even if you give histamine to block this pathway, even if you give H2 receptor antagonist to block histamine in this pathway will still go on to produce what? Acid. That's why the use of PPI are important, because when you use PPI will block the proton pump in this pathway the same as this pathway. So in both pathways, the PPI block the proton pump and hence acid wouldn't be produced. But the H2 receptor antagonists, they only block one of the pathway. That's why they are less effective as compared to the proton pump inhibitors. And then to the second question on H2 receptor antagonists. Which organ is mainly involved in the elimination of the H2 receptor antagonist? In other words, when you take in the drug, which organ does the body use to get rid of a medication, to excrete or metabolize a medication? With PPIs, if you remember, we said the elimination is by the liver. That's with PPIs, proton pump inhibitors. But with the H2 receptor antagonist, elimination is rather by what? The kidney. And for that matter, in a patient who is kidney impaired with the H2 receptor antagonist, you have to be cautious. You have to adjust the dose. But with PPI, you only adjust the dose when the patient is what? Hepatic impaired. Now to the last question on H2 receptor antagonist. State examples. I know you know them. And then some common side effects of H2 receptor antagonists. Side effects are important so that you can make the patient aware that these medications that they are taking can actually cause these side effects. So examples, we have cimetidine, we have ranitidine, we have famotidine, we have nizatidine. So if you are told to mention examples of H2 receptor antagonists, you can mention these. And some of the common side effects of H2 receptor antagonists. So the side effect is some patients may have constipation when they take them. Some too may also have, instead of constipation, they would rather have diarrhea. Some may also have myalgia. This when the patient will feel a muscle pain. And last but not the least, we can also talk about dizziness. So if you are to mention some of the common side effects of H2 receptor antagonist, these are some that you can mention. Or if you are to make your patients aware of them so that they wouldn't be alarmed when they are experiencing some of our these. Next Q&A guide will be on antacid. The antacid, they neutralize the H+ that is produced by the proton pump. So our first question on the antacid is, state some interactions of the antacid with other medication and how to avoid those interactions. So antacid can interact with other medications, and some of these medication that can be interacted with the antacid, one of them is iron. So iron needs an acidic environment for its absorption. You are taking an antacid which will neutralize the acid, so it will reduce the acidity of the GI or of the stomach, and for that matter, iron absorption will be decrease. So with iron there is decreased absorption when you give them with antacid. How do we avoid it? Is by counseling your patients to take the iron supplement to at least 2 hours before or after taking the antacid. So you take it 2 hours, at least 2 hours before or after taking your antacid. Very simple, so that your iron will be absorbed so well as your antacid will also work effectively. Another class of drug is certain types of antibiotics like quinolones. An example of these, you have ciprofloxacin, levofloxacin, norfloxacin, etc. So they normally end with fluoxacin. So antacid, because they contain multivalent ions, so when you take major or some of these antacid medication, you find multivalent ions like magnesium, like aluminium, like calcium. So when you take antacid and quinolones together, this multivalent ion, whether being magnesium, aluminium, or calcium, they form a chelate. They form a chelate with a quinolone, and this chelate is non-absorbable. It's very difficult to be absorbed in the body. So the interaction here is also reduce absorption of the quinolones. So how then do we solve it? It's the same thing with the iron. Is you take your quinolones, your cipro or levofloxacin at least 2 hours before or after your medication. So it's the same with this one. The same go for other class of antibiotics, tetracyclines. An example is doxycycline. With that one too, there is also a reduced absorption as a result of chelate formation. And with the same thing too, for you to avoid them, you just take the medication 2 hours before or after the antacid. The other interaction that we can talk about is magnesium containing antacid. So antacid which contain magnesium alone, are known to cause diarrhea. And those that contain aluminium are known to cause constipation. So normally most antacid contain the two of them, magnesium and aluminium, so that the diarrhea and the constipation will cancel out. But those that contain magnesium alone, like milk of magnesia, it contain magnesium hydroxide. One of its major side effects is diarrhea. That's if you take the medication at a higher dose. So one interaction with magnesium containing antacid is giving such medication in a patient who is already having diarrhea, or giving such a medication to a patient who is given a laxative already. So plus laxative or in a patient who is already having diarrhea, you will worsen the diarrhea, because the magnesium in those types of antacids, they contain just magnesium alone. They are able to pull water into the intestine, and then that can lead to diarrhea. The aluminium containing antacid, as I said, they causes constipation. So ways that the manufacturers have solved this situation is by combining the two. But in a situation where you have just aluminium containing antacid, you are concerned about constipation, and for that matter, giving them with medication that also cause constipation, like opioids like morphine, pethidine, etc., will increase the risk of constipation. The risk of the patients having constipation will be high, because the aluminium causes constipation, and these medications too, they also cause constipation. So one way that you can avoid them, or one way that manufacturers have helped to avoid them, is by combining the two, magnesium and aluminium, so that the diarrhea and the constipation will cancel out. The other interaction with medication that we can talk about has to do with antacid with PPIs. So these two, they are given together, but you have to be mindful of how to give the two together in order to ensure the effectiveness of the two. If you remember, I said PPIs, they are prodrug, meaning they are inactive and they need to be activated. They need an acidic environment in the parietal cells to be activated, so that they can get into their active form to block the proton pump. So if you take antacid, the antacid will rather reduce the H+ or the acidity, and for that matter, the proton pump inhibitors their activation will be impaired, and for that matter, the proton pump inhibitors wouldn't be effective in treating your peptic ulcer disease. So ideally, whenever you are giving antacid and proton pump inhibitor, in order to ensure effectiveness of the proton pump inhibitor, you space the administration at least 2 hours. So you give your proton pump inhibitor, 2 hours later you give your antacid, so that your proton pump will be activated and then will function before you can give your antacid. And the next one will be a question and answers on Sucralfate. If you remember, it's one of the protective. They cover the stomach mucosa so that, or to prevent an attack from the stomach acid and the stomach juices or enzyme like pepsin. So what is it made up of? So Sucralfate is made up of a complex of aluminium and a sulfated sucrose, hence the name Sucralfate. So aluminium and then sucrose and then the sulfate. What common side effects based on the composition can you think about? An interaction that we can think about. What did we say about aluminium? Constipation. So one common side effect of Sucralfate is it can cause constipation. You have to make your patient aware. And then based on the aluminium that you contain, one interaction is, or drugs that they can interact with them include the quinolones that we talk about, your Cipro level, and then norfloxacin, or your tetracyclines like doxycycline. So these drugs, as we said, because of the aluminium, they form a chelate. They form a chelate with the aluminium. So when you take the Sucralfate and the quinolones or tetracycline together, because of the aluminium, these drugs bind to the aluminium to form chelates. And these chelates, they are non-absorbable, meaning it will be very difficult, or their absorption will be inhibited. So only small amount of the antibiotics will get into systemic circulation. And for that matter, you also have to space their administration by at least 2 hours. Then to the next guide will be on Bisthmuth Subsalicylate. So our first question will be how they are able to manage or treat ulcer. So 1, the bismuth in Bisthmuth Subsalicylate is antibacterial. Antibacterial here means they can kill bacteria, and one of the bacteria they can kill is H. pylori. And as we said, one of the aggressive factors or causes of ulcer was H. pylori, and therefore Bisthmuth Subsalicylate, normally seen in Pepto-Bismol. One way of managing ulcer is by killing H. pylori. Another way is as a protective. Just like the Sucralfate, they also form a protective layer over the stomach mucosa to prevent the stomach acid, pepsin, and other aggressive factors like bile salts from attacking the stomach mucosa. So the other way of ulcer management or treatment is by being a protective. And then one other way, or the other role that they play in ulcer management, is by stimulating the synthesis of the useful prostaglandin. So we said prostaglandin is one of the protective factors against the stomach acid, the pepsin, and the likes. Bisthmuth subsalicylates are able to stimulate the body to produce prostaglandin. So they are able to manage ulcer by three main ways: the bismuth being an antibacterial, as a protective, and by stimulating prostaglandin. One of the common side effects with Pepto-Bismol or Bismuth subsalicylate that you have to make your patients aware is that they cause dark stool and tongue. So they cause this dark patch on tongue or stool. So you have to make the patients aware so that when they see those things, they wouldn't be so much concerned. So to our last Q&A guide will be on Misoprostol, which is also one of the class or one of the example of anti-ulcer agents. So our first question will be, we said Misoprostol is a prostaglandin that helps to form the stomach mucosa to protect the mucosa from acid. So our first question is, what type of prostaglandin is Misoprostol? It's a synthetic prostaglandin. So what type is that prostaglandin? So the type is prostaglandin E1. So Misoprostol is a prostaglandin E1, which is synthetically made to be similar like the useful prostaglandin that the body produces to protect the stomach mucosa. Misoprostol at certain dosages can inhibit acid secretion, and at a particular dose to act as a mucosa protective. So at lower dosages from 50 to 200 microgram, they are able to inhibit acid production. And at dosages greater than 200 microgram, like 400 microgram, they are able to serve as a mucosa protective. Beyond 400 microgram, we will be experiencing a side effect of the Misoprostol, which is they are able to stimulate uterine contraction. And if someone is pregnant and the person is being put on this medication, there is a high risk of the person losing a pregnancy. So for PUD, the recommended dosages are within this range. The recommended dose shouldn't be more than 400 microgram. So normally it's normally given in PUD at doses about 200 to 400 microgram 2 to 3 times in a day. To the side effects, we can talk about abdominal cramps, severe one, diarrhea, headaches. It's one of the common side effects of Misoprostol, and therefore you have to make your patient aware. Thank you. This will bring us to the end of our content on anti-ulcer agents. We started with the classes, we move on to proton pump inhibitors, and I tried to use the Q&A guide to also talk about some useful information on the other anti-ulcer agent. Thank you. I'm Dr. Leon. This is my channel. Please subscribe.